talk about uh, little nuances depending on how the patient presents, like what their mechanism was. Uh, the main goal from a public health standpoint is to provide quality healthcare at a low cost. And obesity, as I just mentioned, that's a widespread issue, and we'll get into a couple of the statistics in a minute. And so is trauma. And so it's really important to understand what are ways that we can minimize the cost of these things and identify areas of improvement. And I think the first step is just, making everybody aware that obesity in trauma really should be a specific area that we all are educated in, and it's not often included in textbooks or even the training that we receive. All right, so this slide shows that the United States is the most obese country in the world. Even 10 years ago, greater than a third of people in America were obese, but now that's actually up to over 40%. So that's a pretty massive increase in just a short period of time. Also, and we'll go through the breakdown of the BMIs and what classifies, overweight versus obese in just a minute. But now almost 10% of our population is classified as being severely obese or morbidly obese, and that's actually doubled in 20 years, which is concerning. All right, so just to talk about the definition of obesity, the slide shows the BMI calculation, which I'm sure we all remember having to do at one point or another, but it's basically the kilograms in body weight divided by height in meters squared. And as you can see, normal and underweight goes up to 24.9, and then you are classified as overweight from 25 up, and then 30, you're obese. Greater than 40 is morbidly obese, or sometimes it'll be referred to as severely obese. And that's doubled over the last 20 years or so. So this is the population that we'll be focusing on, BMI 30 and greater. All right, so what is the current state of trauma? It's the leading cause of mortality for young people, especially under the age of 45. This comes in the form of MVCs, falls, which is kind of a bimodal distribution, the very young and the very old, firearms, burns, and then even workplace injuries, especially in young patients who are still in the workforce. And then take a look at that bottom statistic, because this is pretty striking, that obesity alone, if you come in for a blunt trauma, increases your mortality 6-fold. And that's huge. So what are some of the consequences? Financially, it's huge. Almost $500 billion is lost because of loss in productivity by patients, and then the cost of healthcare for caring for obese patients. Some of the things listed on the left we'll touch on in a little bit for why this cost is so high. But on the right side of that slide talks about the healthcare outcomes from obesity. Obese patients after a trauma will stay in the hospital longer. They're on the ventilator longer. They die more often, more complications. And then oftentimes that's when a lot of their comorbidities from being obese are diagnosed. Okay, so this triangle here shows what drives up the cost of healthcare, which is at the center of it. So on the bottom right is equipment. And so that could be things like, the number of ventilators for obese patients who are requiring mechanical ventilation for longer periods of time. It could be specialized beds, the ability, mats to transfer a patient to and from an operating room table, things like that. And also long-term, after they leave the hospital, equipment that they need long-term. To the bottom left is infrastructure, and that's the cost that goes into developing evidence-based guidelines to help us provide this best possible care for obese patients. And then also, the money put into education to try to prevent obesity in the first place. And then up at the top is education, which is, kind of what we're trying to do right now, making everybody aware of the issue and hopefully improve healthcare and drive down costs over time. All right, so to talk a little more about injury patterns, this slide shows blunt, penetrating, and blunt, penetrating, and burn. We'll talk about blunt first. Motor vehicle collisions, probably the most common. In obese patients, there's actually been shown that they wear their seatbelts less often, which also is going to increase morbidity, mortality related to the trauma to begin with. And then also these patients tend to have falls at a younger age. And then these falls tend to lead to more complex issues. So, you have a younger obese patient who falls, dislocates their knee, has a popliteal artery injury, then it becomes kind of a domino effect of some of the complications and problems that they may have versus if the patient had been a normal weight. And then workplace injuries are common, again, in young people who are still in the workforce. The cost of missing out on work is significant because of that as well. And then I just want to point out the equation for energy, kinetic energy. Everybody's probably flashing back to physics and science classes, but the equation 1/2 mv squared, with m being mass. So you can see that as you increase your mass, you are increasing the energy of the trauma. So, think of that with these patients in a motor vehicle collision, for example. Then under penetrating trauma, missed injuries, that's a real problem. It's very easy in an obese patient to miss an injury, either because if they're morbidly obese, you may not be able to adequately turn them to see every square centimeter of their body, or maybe there's a skin fold that is hiding an injury, and that happens. And as far as burns, you've all probably heard of the rule of nines. I'll show you that here. To estimate the total body surface area, typically it's multiples of 9, so the upper extremity is 9, anterior lower extremity is 9, posterior is 9, for a total of 18. The thorax and torso in general, 36%. But in obese patients, it's actually the rule of fives. That's what they say. 50% is going to be in the trunk versus 36%, like you see with the rule of nines, and then 20% each leg, roughly. So, it even affects burn care and burn resuscitation, because the total body surface area of a burn is significant when we're resuscitating these patients. So whatever mechanism of trauma a patient comes in with, obesity plays a role. Just to elaborate a little bit more, especially with blunt trauma, why these patients have sometimes more severe injuries. We talked about the mass increasing the energy of the collision if it's an MVC, for example. But these patients also have more extremity fractures when they're obese. Although they may have fewer liver lacerations because there's more subcutaneous tissue to kind of absorb that force. And then, although there might be fewer head injuries in general in obese patients, they tend to be more fatal, probably just because of all these other complications that come with obesity. And then if you have an increase in rib fractures and pulmonary contusions, that also is going to feed into a longer time requiring mechanical ventilation, which an obese patient was already prone to. Oh, and then another thing I want to mention is the increase in fractures could be related to a relative vitamin D deficiency because of adiposity. As far as injury patterns, male and female, the center of gravity is different, and so that can sometimes impact where injuries are sustained. And then, obesity occurs in children too. It's not just adults. In fact, the rate for pediatric obesity is now around 20%, which is high. And the way that they define obesity in a child is a little bit different than an adult. They don't usually go by a BMI calculation so much as it's their growth specific chart for age in the 95th percentile is what they define as obese. Okay, so now we'll kind of shift gears and just review some of the physiologic changes and derangements that occur in obese patients. Okay, so from a cardiovascular standpoint, obese patients tend to, be at higher risk for hyperlipidemia, diabetes. Then they may develop atherosclerotic disease, have a higher risk of stroke, MI, a lot of cardiovascular effects because of this. Also, because of increased systemic vascular resistance, you can develop hypertension and cardiomyopathy, which is just like a gradual dilation of the heart. And then cardiac output is increased because of the increased circulating blood volume of an obese patient. That increases the stroke volume and the cardiac output as well. From a pulmonary standpoint, these are some of the changes that you'll see in obese patients as compared to a normal weight patient. But basically, even the weight of the chest wall is substantial and significant and can have some pretty dire effects on a patient, whether it's leading them to mechanical ventilation or being able to wean them. And then obstructive sleep apnea at the bottom is often one that the patient is not aware that they have, that then ends up being diagnosed while they're with us in the hospital. And it's also important to note that the cardiovascular and pulmonary complications that we just talked about in the last two slides are twice as likely to occur in an obese trauma patient versus a non-obese, 12% versus roughly 5%. These are some of the changes that you'll see within the kidneys. A lot of insulin resistance is what happens. Oh. Also, you get an increase in cortisol, which has a lot of downstream effects as well. Obese patients in general, but also an obese trauma patient is really at high risk for VTE, DVT, PE. It's a hypercoagulable state. a lot of the reason is because of um, the conversion to estrogen in the adipocytes. Obese patients are obviously going to have more adipose tissue for this to happen. It's kind of the same thought as why um, women on oral contraceptives have an increased risk of thrombotic events. It's the same idea. All right, we talked a little bit already about the increased fractures in trauma, but in general, at baseline, the bones and the joints, ligaments, tendons, everything has more stress, carrying around more weight. These patients oftentimes have chronic pain related to this. They may have osteoarthritis as well. So that's just another factor. Some of the comorbidities that we do see in obese patients are listed on the left: hypertension, stroke, MI, renal disease, sleep apnea, um, even asthma. Um, and it says caution, patient may not be aware, because again, a patient may not realize that they have these comorbidities until they come in and we tell them that they do. So just keep that in mind, especially when we're getting a history, either on their way to the hospital or once they're in the trauma bay, or even once they're on the floor, when we're getting their full medical history. They may not have much to tell you, but there may be some underlying issues that will impact their care that they aren't aware of yet. All right, common complications. Once a patient's here in the hospital, infection, whether that's a UTI or a wound infection, um, the incidence is greatly increased in an obese patient versus a normal weight patient. The wounds, if we have to do an exploratory laparotomy on a patient for trauma, um, the wound infections happen, unfortunately, pretty frequently because of the increased thickness of the abdominal wall, poor healing, numerous factors, poor nutrition. Maybe they're sicker on the ventilator because we're having trouble weaning them. It's all so multifactorial. The patients also can get more pneumonia, DVT, as we discussed already, and then abdominal compartment syndrome is listed here. And an obese patient is likely going to have a lot more intra-abdominal fat than a normal weight patient. And this can vary between males and females even, and then just between person to person. But in general, there will be more intra-abdominal adiposity, and so that increases the pressure already within the abdomen, and that can become significant for us when we're managing massive transfusion and just a critically ill patient who's obese. Acute respiratory distress syndrome is another reason it might be difficult to wean from the ventilator, and then multi-system organ failure as well. Okay, so now we'll shift back to talking about more practical applications of this and how to apply the things that we just talked about. Some special considerations when a patient, is en route to the hospital or arrives at the hospital and then beyond even. So pre-hospital, this can be pretty challenging. The patient might not even be able to lay completely supine. Um, again, because of the weight of the chest wall, their neck tissues, which we'll talk about momentarily, may make it difficult for them to be supine. Um, you know, Getting a patient onto a backboard, transferring them is more challenging with an obese patient. You need more people to do it as well. Splinting a fracture can be more difficult. Finding a C-collar that fits even, blood pressure cuffs that fit, and even IVs that are long enough to reach the veins through all the subcu tissue. Oh, and I didn't talk about evacuation. Also, to try to extricate a patient from, say, a car accident would be much more difficult as well. All right, so now to run through, A, B, C, D, E of the primary survey, starting with airway. Uh, Obese patients have oftentimes shorter, thicker necks, and they're unable to extend as well. You lose your landmarks. Um, it can be a dangerous situation if you're worried about a patient's airway. If they require intubation, it makes it extremely difficult. Um, Also, to make that even worse, because of the increased intra-abdominal fat, you'll have more reflux in an obese patient than you will a normal weight patient. And so that can put them at risk for aspiration as well. Also, there's a weight limit to a backboard, to tables, everything. And so that's another consideration in a super obese patient. Uh, so what are some things that we can do to try to help with this? We can try to elevate the head of the bed. If they can sit up at the hip, then we can do that. But if not, you can do reverse Trendelenburg to just, tilt the entire bed so that they're head up, just to try to bring some of the weight from within the abdomen off the diaphragm, help them breathe, help to bring all their subcutaneous tissues down and out of this airway location that we need to, control first. Um, if you can't find a C-collar that works, sandbags and tape. I've seen that before. And then you just have to be especially careful with controlling the cervical spine. Make sure that there's someone that's their job, is they're dedicated to holding the patient, in line. And then also early insertion of a gastric tube to decompress the stomach and hopefully prevent an aspiration event. Um, and then, if we're having difficulty intubating, make sure you have all the equipment that you may need to make that happen. Experienced hands if they're available. And then, you know, you might have to do an early surgical airway. Um, these patients don't recover as quickly as a normal weight patient. And so you don't want to let them desat, down to 80 before you're then considering doing a surgical airway if the intubation has failed. That can be devastating. All right, to move on to B, and we talked a little bit about breathing with airway just a moment ago, but um, basically the increased intra-abdominal fat displaces the diaphragm, um, increases the pressure, uh, makes ventilation and breathing more difficult. Um, so these are all things that we need to consider too. I talked about reverse Trendelenburg to try to help with that. Um, and then at the bottom, anesthesia assistance. If you're predicting a difficult airway and they're available, it's if you can get the most experienced hands, that's best. Uh, Also, positive pressure can be helpful. Using two people to mask the patient. Um, Chest tube placement can be difficult in a super obese patient as well. So just all these things become a little bit more risky. Awake intubation we don't typically do in a trauma setting. It's usually a rapid sequence um, to try to prevent aspiration for all the reasons that we've talked about. And then, as I had already mentioned, if you do fail at intubation, it's going to take longer to get their SATs back up and to get them to recover. They can decompensate very, very quickly. Even with a successful intubation, they can desat very quickly. There was one paper that notes a 35% rate of failed intubation if the patient's neck is greater than 60 centimeters in diameter. So that's how risky it can be. Moving on to circulation. With all the increased subcutaneous tissue, it can be difficult to even palpate pulses. I think most of us have probably been in that situation where it's actually hard to palpate a femoral pulse. especially during, a code event. A lot of the times these patients are hypertensive at baseline. And so if they're normotensive for us, that actually might be a relative hypotension for them. And usually we resuscitate people based on their size and weight. And so obese patients tend to get less fluid for resuscitation. And so that's just something to keep in mind, is we tend to give them quite a bit less than we would a normal weight patient within the first several hours of their resuscitation. Other things to think about: IV access. Do you need a longer needle? If you can't even get access at all, then IO is still a good option in an obese patient. It's a safe way to get fluid in and then hopefully be able to get venous access if we're struggling with that. For monitoring intra-abdominal hypertension, that can happen if you have massive resuscitation in a patient. And then, as we talked about already, there's much more adipose tissue within the abdomen of an obese patient, and that already will increase pressure compared to a normal sized patient. So you'll want to keep that in mind as well when we're resuscitating these patients. And then the cardiovascular assessment at the bottom, just monitor lactate, ABG, things like that to help us with that assessment. And then a transesophageal echo can be helpful. They're called an IMACOR in some places, but that can also be helpful to assess their resuscitation volume status and whether they've received enough. Disability. A lot of these patients don't realize that they have sleep apnea, but that could be a reason if they're kind of lethargic when they present. It's hard to rule out if they have a head injury, but maybe it's just because they're lethargic from apnea. So just something to keep in mind. You'll just want to keep an eye on them, watch for any changes in their GCS. Make sure we still attribute a low GCS to trauma until proven otherwise. We don't want to fall into the mistake of thinking, oh, this person probably has, obesity, hypoventilation, and sleep apnea, and therefore that's why they're somnolent. We don't want to assume that, but if we can rule out a traumatic etiology, that could be playing into it. And then you need to way in advance start thinking about discharge, where they'll go, how to make that happen, because they oftentimes will have some special needs. It takes longer to bounce back to their pre-trauma baseline, which is important to establish. What were they able to do before this happened, and how do we try to get them back as quickly as possible? For exposure, we kind of talked about the longer entrapment times out in the field, but that's something to consider. They may come in hypothermic. And then you have to look over every square centimeter and under folds, lift up the pannus, lift up the arms, examine axilla, the groin, perineum, everywhere, just to make sure that you're not missing a wound. I've definitely seen it happen in a gunshot wound scenario where an injury was missed. This was not here, but it happens. And it's more difficult to identify these things if the patient has multiple folds. These are just some of the things that you may need to consider as far as, big enough moving boards, having enough people to help you. All right, so adjuncts now to the primary survey. When we're trying to get our images, whether that's CT, ultrasound, X-ray, it's harder to have a clear image when there's more subcutaneous tissue. So reduced quality of our images, which we really need in a lot of situations to establish what injuries are making the patient sick, et cetera. A lot of the times the CT scanner may have a weight limit. Sometimes it's 200 kilograms. It depends on facility. but 70 centimeters is often the diameter limit, and so some patients just cannot fit in the scanner. Um, Also, you may have to take a patient with a blunt abdominal trauma to the OR before you normally would for a normal weight patient. You might not be able to see what you need to see, and if a patient's unstable, it really gives you no choice but to go to the operating room for something that maybe you didn't actually have to. Uh, could you have actually accurately evaluated the patient with imaging? If patients have large arms, it's sometimes hard to find a blood pressure cuff that fits them. And if that's the case, you can try taking a pressure on the forearms. Um, you can use pulse ox on the earlobe. That's another thing that helps while we're doing our workup. We already talked about using a gastric tube. Um, and then, just try to be compassionate and understanding. A lot of the times, um, patients will realize if they're super obese that, that it's harder to care for them. And they're often self-conscious of that too. And so just keep in mind your own bias and, try to just recognize that and, treat everybody the way that everybody deserves to be treated. You also need to be aware of the medication dosing because um, if you don't actually calculate it for their weight, you may be way underdosing them. And then also you need to determine, is this supposed to be dosed on ideal body weight instead, actual body weight, et cetera. So pharmacy should be our best friends in that situation. All right, and so then when we're finishing up our survey in the trauma bay, uh, make sure that you look at everything, try to palpate, any deformities, which can be difficult to identify sometimes as well in an obese patient. Um, and then trying to get a good history the best that you can. And keep in mind that they may not know that they have some of the comorbidities that they do. Get enough people to help you when you're turning them to examine their back. Keep in mind, the width of the bed. Don't want anybody to fall. And then, we've talked about a lot of these things, but um, just a lot of considerations for patients who are especially super obese. Uh, make decisions on where the patient will go as early as possible. If you're at a smaller hospital and you need to get the patient transferred elsewhere, start thinking about that and making it happen because there may be more factors at play than for a normal weight patient. Even deciding if once they're admitted, even deciding where they should go after discharge, all these things need to be thought about well in advance. All right, so now shifting gear to after the initial resuscitation. Uh, Obese patients have a lot more post-op complications. Um, they develop more significant atelectasis a lot of the times, again, probably related to the weight of the chest wall and the increased adipose tissue within the abdomen, difficulty fully expanding the diaphragm. So atelectasis may be more of a battle than for a normal weight patient. They're more prone to infection, anastomotic leaks if you have to do a bowel resection. The thickness of the abdominal wall can make bringing up an ostomy more difficult. They're much higher risk of getting a deep soft tissue infection or even of that limb of bowel dying. So they're just all things that make the operative care and post-operative management a little bit higher risk. On the right side, they mentioned abdominal compartment syndrome, and we kind of touched on that, but this slide is more referring to just having the increased adipose tissue, not so much abdominal compartment syndrome as we use the term in the ICU, which can be related to fluid resuscitation. So it's kind of a different way that this is being used on this slide. All right, and then again, missed injuries. It happens often, not often, but enough that it makes you think of it when you have a super morbidly obese patient. You have to check everywhere and keep in mind that if you say have a gunshot wound, you may not really be able to accurately identify the tract of the bullet. Also, it's not obvious if they have certain fractures, just because of the amount of subcutaneous tissue that they have. And we already talked about the limitations with some of the imaging. With fractures, casting is more difficult. Finding a brace, which is shown in the picture, TLSO brace to fit the patient can be difficult because of all the other comorbidities. These patients may require amputation more frequently than a normal weight patient if they have substantial extremity injury. Compartment syndrome of the extremity is something to consider, and it can be a little bit harder to diagnose in a morbidly obese patient because you have the increased subcutaneous tissue plus edema, and it just makes it a little bit less straightforward. And again, we mentioned some of these causes for increased mortality, but these patients get infected, require operations more, and it can become a pretty bad problem for them. Again, pharmacy, the pharmacist, use their knowledge. They can help with the volume of distribution that's going to be different for a patient with a higher BMI. They can help determine, are you supposed to dose it based on the body weight or ideal body weight, and then they can help monitor and make sure that the dosing is actually adequate based on the patient's hepatic and renal function as well. Nutrition is another factor. These patients are obese, but they're often malnourished. We want to get them high protein diets and make sure and consult nutrition to help out with that. We already talked about pharmacy, and case management social work can help, especially when we're trying to figure out what is best for the patient long term. And then getting their primary care providers in the loop helps as well, especially when some of these comorbidities from obesity are diagnosed when they're in the hospital. It's important to try to develop guidelines the best that we can to ensure that we're delivering the highest quality care that we can for any subset of patients coming in as a trauma. The functional independence measurement is measured admission, discharge, and then post-discharge. And some of those domains are listed there. It just basically tells us that it takes a lot longer to recover as your BMI goes up, as your age goes up, and your injury severity score also increases. All right, so just to summarize, obesity is widespread. It's only going to increase, unfortunately. Trauma, unfortunately, is also always going to keep happening. And so it's really important that we're all aware of, the special nuances required for caring for more obese patients. And then, trying to find ways to improve the care long term for them as well.